Another thing that we know from data is that clinicians, and I would say especially physicians, are very reluctant to access professional resources because of some structural and cultural barriers. The structural ones are, for example, the fact that in some states still, and many states in the past, when you're applying for your licensure, you have to declare whether you've ever received mental health support. And that is seen as a huge barrier because, frankly, it's none of their business whether you have, and it's discouraged people from getting the help that they need, even if it's about true mental health issues or just transient reactions to stressors. So that's an example of a structural barrier, and people do fear their for confidentiality and stigma for having sought professional help. And then I think there's cultural barriers, so including general stigma, but also we've been taught in so many ways that self-care is selfish, that we are there to be altruistic and always put patients and others first, which generally speaking, of course, that's going to happen, but never processing our own emotions, never providing ourselves with care and self-compassion, or having others help us with that. That's what's unsustainable. So I think in order for us to develop programs, we have to really understand what the cultural barriers are and also work towards changing that culture. And so when you're building a program to try to help get emotional support to clinicians, you have to look at the fact that there are these barriers and not just say we have a great mental health program, because the chance of individual clinicians being willing to access those programs is quite low. And so one of the functions of having a formal peer support program is for both to help the clinician, the peer, process what they're feeling, but also destigmatize and facilitate referrals for further professional resources should the peer want them.